Good morning. It's a pleasure to have a chance to speak during the Bio Conference Live this year. I'm Cinnamon Bloss from the Scripps Translational Science Institute in La Jolla, California. And this morning I'll be talking about return of genome sequencing results to physicians and patients. And I just want to add before I start, please feel free to submit your questions. And I will address them at the end of the talk. All right, so in order to get at some of the issues around return of results and genome sequencing, I'd like to focus on describing a bit about an initiative we have ongoing at Scripps that we call our IDIOM study, or Idiopathic Diseases of Man study, where we are trying to utilize sequencing for diagnosis and treatment of idiopathic diseases. And this is a study where we are recruiting cases where the patient has been essentially on a diagnostic odyssey, has had every medical procedure and test under the sun, but has yet to have an answer as to what their diagnosis is or how, if at all, it can be treated. We started this project in the fall of 2011, so it's been going on for about 2 years now, and we've enrolled our 10th patient in the study, but I'll be focusing on describing the first 5 cases that we've enrolled, giving you some kind of very early case study data on return of results, and also describing a bit about the procedures, the cases themselves, how we return results in this study, and most importantly, describing some of the lessons that we've learned so far in conducting this project. So the main points of interest that I'd eventually like you all to take away from this is to get a sense of what are the characteristics of the physicians and patients that we're seeing in the context of this study. Importantly, and as you'll see, these patients and physicians are unique and may not, in fact, be representative of all the types of patients who may ultimately benefit from clinical sequencing. Also, what are sort of the attitudes and expectations of both the physicians and the patients that kind of sign up for a study like this? Do they have false hope? That's been a concern in the literature. What types of data do they expect access to? Do they expect to know findings from clinical sequencing beyond just results that may pertain to the presenting condition for which they've been on the diagnostic odyssey? That's been a big debate in the field for the past few years, is the issue of kind of secondary or incidental findings, and to what extent do we look for these in clinical sequencing analysis, and then to what extent are those results returned? So I'll be talking a bit about that. And then also, importantly, in our study, the way that our protocol works is that we actually have the physicians themselves receive the results from us, and then it's really up to them as to how they return those results to the patients and the families, and sort of what aspects of the results they deliver. And we've been sort of closely studying this process as a way to just better understand how well equipped, if at all, physicians feel to be able to do this type of work. So I'll show a little bit of data, early data that we've collected pertaining to that issue. So just a bit about IDIOM itself, the criteria for enrollment. The patients that are enrolled in IDIOM, we actually enroll the patient and then the biological parents, so a trio. The patient has to have a condition that's grave or severe, if not life-threatening, severely quality of life-threatening. The condition has to have been undiagnosed despite, as I mentioned before, extensive medical follow-up. The symptoms need to appear genetic and to have the potential for improvement via sequencing. So, we need to have a sense that the sequencing would be informative for the case. Also, this hasn't been an issue for too many of the patients that we've enrolled to date, but because there at this point in time there can be a turnaround time issue for sequencing. We look for cases where there's a life expectancy consistent with, again, being able to benefit from those sequencing results. And then finally, a very important piece of our study is that there needs to be a physician champion who is willing to actively participate and engage with the research team on behalf of the patient, and also be willing to take responsibility for the return of results. Okay, a bit about IDIOM procedures. Cases are referred. They're often referred from physicians, but also from family members. The patients are often self-referred as well. They undergo an initial screening by a nurse coordinator who works on the project here at Scripps. Cases that appear to meet sort of general criteria for the study are then forwarded for review to our clinician scientist review panel that's made up of a group of about sort of 15 physicians who are sort of on call for a series of review meetings that happen roughly quarterly. And then also members of the research team, including bioinformatics specialists, sequencing specialists, psychologists, and ethics people as well. We also have membership from or representation from our IRB on that panel. For cases that the panel chooses to enroll based on the criteria, they then provide their blood for sequencing and analysis, and then prior to actually receiving results, we do a sort of psychosocial and ethics assessment, both pre and post sequencing, which I'll describe in a minute. And importantly, in the context of our current protocol, the way that return of results works is that we are only at this time returning primary results that pertain to the presenting condition, but are very interested in expanding the protocol potentially to include return of secondary findings. And so that's one reason that we've been very interested in kind of collecting some initial data from these patients based on what are their preferences for return of results. Importantly, we also only return results to the patient. Potentially because parents are being sequenced as well, you could imagine that there may be results in the parent genomes that could be relevant. So we ask about that as well. At that point, once we conduct the analysis, develop the results, put it into a report, that report is given to the physician champion. The physician champion is then offered the opportunity to have sit down and meet with our research team to go over those results, to really try to support that physician as much as possible in his or her delivery of the results to the patient, in his or her possibly utilizing the results in the patient's care. So as I mentioned before, we have a very dedicated group of scientists and clinicians who serve on our review panel. Many of our meetings take place in the evenings or at lunch, so it is quite a dedicated group. And as you can see here, it's also representative of really a range of medical specialties, neurology, internal medicine, allergy, immunology, and so forth. So for the psychosocial ethics piece of our assessment protocol, we like to get at a number of different sort of facets of the process. So trying to better understand what are the patient characteristics associated with kind of this unique population. What are the physician characteristics? Are physicians that might tend to refer patients for a sequencing study like this? Do they differ from your average physician in certain ways? For example, you could imagine that perhaps physicians willing to do this might be more recently trained, having had more exposure to genetics potentially, or perhaps they just take kind of a more innovative attitude towards medical care, are among the first in their peer group to adopt new medical treatments or interventions. And so these are things that we try to measure and better understand. We also ask both patients and physicians about kind of different aspects of their attitudes towards the sequencing. So, do they have any concerns about privacy, concerns about being able to interpret the findings? As I mentioned earlier, what are their preferences for return of findings that, secondary findings or incidental findings? If those findings were available in our protocol, would they want them? We ask about that. And then very importantly, we also seek to find out more about sort of the actual communication of the results themselves. We do that via an instrument called the Medical Communication Competence Scale. I'll describe a bit more about that a bit later, but this is really focused on sort of how well the physician actually delivers their genomic sequencing results compared to how well they communicate in general. So hopefully we'll be able to show you some of our early data that may sort of pique your interest about this particular issue. And then finally, post-sequencing, we also ask about the impact of the sequencing itself. Do either the patient or the physician or the parents have any regrets about undergoing sequencing? How impactful was the sequencing? Was it distressing? And so forth. So just to give you a sense, to date we've received 101 referrals for our IDIOM study over the past 2 years. They've come from all over the U.S. and also we've had a number of international referrals as well, although certainly the majority of cases are from California, and more specifically Southern California. And these are sort of the specialties and phenotypes that are represented among these referrals. And we've been tracking this closely. Many of you may be aware of the program at the NIH called the Undiagnosed Diseases program. And that group has published a number of information about their program, including the specialties represented, the number of referrals, and so forth. And so we've been tracking this as well to try to get some idea of sort of the overlap in specialties seen by our 2 different programs, also the most common specialties observed. And as you can see here, by far, neurology is sort of overrepresented among this referral population. And this is very consistent with what the UDP is seeing as well. They've published data suggesting that sort of neurology is one of their top specialties as well. We're also seeing hematology, oncology, cardiology, allergy, immunology, and a number of other specialties as well. Okay, so just some data on our referrals as a function of whether or not they were deemed ineligible versus whether or not they went to a full panel review. And what you can see here is that the panel has reviewed roughly 33% of the cases that we've received. Clearly from these data, we're much more likely to see cases that we feel would be appropriate, that meet inclusion criteria among sort of the end of the spectrum in terms of cases that are reviewed. And when you simply look at sort of the proportion of cases that are children sort of under 18, much higher proportion among the cases that our panel has reviewed. Similarly, as I mentioned before, our referrals can come from They can be self-referred, referred by a family member or by a physician, and you can see that cases that are referred by a physician are also much more likely to make it kind of to the next stage of panel review. And then you can also see sort of the top medical specialties that are represented. Neurology is high for both groups, but then once you get to the panel review stage, we're seeing oncology, allergy, immunology, and cardiology being more common. Okay, now I'd like to talk a little bit about sort of some case study data from our very first cases that we've enrolled in this study. So this is data on our cases 1 through 5. You can see the age range represented here, ages 14 to 35. Most of them have been female. Most of them have been European, of European ancestry. And as I mentioned before, we also like to get a sense of the patient's kind of self-rated quality of life using kind of a validated measure of this. And so we kind of ask about 3 different domains of quality of life, including physical, psychological, and environmental. And what you can see here, I'm showing some Z-scores here compared to normative average. And not surprising, based on the inclusion criteria for the study, we're seeing that this group of patients has kind of severely impaired physical quality of life, very consistent with having, a very serious illness. They fall at about average in terms of their psychological and emotional quality of life, which could be expected, I suppose. But what I think is interesting is when we ask about environmental quality of life, so things like how well supported they feel by sort of family, how, to what extent they feel they have financial resources, those sorts of things. We're actually seeing superior quality of life among these patients. And I think this is important, and it's not really an issue that gets discussed all that much in these types of studies, but I think what this suggests is that the types of patients we're seeing in these early studies are really, and this is borne out by our observations as well, but they're really very sophisticated families, typically very highly educated. To some extent, this makes sense because really to have been on a diagnostic odyssey, to some extent, a family or a patient has to be sort of savvy enough to, to kind of work through the medical system. And so I think this is important because, it suggests that, there's probably a lot of other patients out there who aren't as savvy, who don't have as many financial resources, that could still benefit from sequencing. And I think, as a field and as a community, thinking through ways to reach out to those types of patients is going to be important going forward. We're also seeing among this group of patients kind of a high average genetic knowledge score. So again, kind of feeding into this idea that these are sort of a more savvy, not your typical group of patients. And so what about the physicians? So the characteristics of the physician champions for these first 5 cases kind of a range in terms of when they completed their training. These are the specialties that are represented. And in terms of the time that they've spent caring for the patient, it kind of ranges from 7 months to several years. So sort of a range that we're seeing there. We also ask about, as I mentioned before, sort of where physicians fall in terms of how likely they are to adopt new procedures and technologies in general. Are they more likely than their peers to do that, and so forth. And in fact, what we're seeing here, this is the personal innovativeness at the bottom of this table, is that they actually in the average range. So this isn't really a group of physicians that are tremendous outliers in this sense, but in fact they're more average. Okay, so now I'd like to move a bit to the issue of secondary findings, preferences for secondary findings, and what we're seeing in our data from these early cases. So bear in mind, this is case study data. I'm certainly not making a lot of strong inferences from this. But just as a reminder, so secondary findings are findings from clinical sequencing or really any medical test that are sort of unrelated to the referral question or the reason why the person underwent sequencing or the other medical test in the first place. And so we ask about preferences for secondary findings. We ask the physicians, we ask the patients, and we ask the parents. I mean, you could imagine, that these groups might differ in terms of what their preferences are. For instance, we had a physician who, who in general wanted to receive secondary findings, but expressed concern that findings for the parent of her patient she would receive secondary findings for the parent of her patient, given that that parent isn't actually her patient. So there's some reasons why we might expect to see different preferences among these different groups. And so what we're asking here in the data that I'm going to show you are data from our pre-sequencing assessment, and we're asking whether or not they would want to receive secondary findings in different categories for them. So what you can see here is these bars represent the percentage of patients out of the five patients, 5 physicians, and then 10 parents that were surveyed. And here we're asking them about whether they would want to receive findings for childhood onset conditions where there really wasn't any kind of screening or treatment available for that condition. And so we're seeing 60 to 70% of individuals in our study saying, yes, I would definitively want these results if they were available. When you go up to adult onset conditions, so something like Alzheimer's, for example, where there are no screening or treatment available, we see that parents kind of tick up to 100%. 100% of them are saying, yes, I would want those findings for myself. Among patients and physicians, it's still roughly around 60%. When we go down to childhood onset conditions for which screening and treatment is available, we're seeing 80 to 90% of parents, patients, and physicians wanting access to these results. And then finally, when we're dealing with adult onset conditions where there is screening and treatment available, one example might be breast cancer, 100% of people in these groups would want to get those findings back. We also ask about the extent to which these groups would want findings related to kind of susceptibility to adverse drug reactions, and similarly, we're seeing a very high percentage of individuals in these groups wanting those results back. And I will tell you that when we reassessed all of these different categories after sequencing, so post-sequencing, after the patients and the families had already received their primary results, in every case, the percentage that wanted these findings in the different categories actually went up. So suggesting that there's quite a strong interest, at least in theory, in getting these results back. I think it's important that to some extent, when you ask patients about, the extent to which they would want these results if they were available, it's kind of a theoretical question. I think, until, they're in that situation, there was actually that possibility sort of sitting in front of them. There could conceivably be different attitudes about that, but I think at this point, it's important to kind of take note that their patients are saying, yes, we want these results. Okay, so I just want to digress from talking about data from our study for a minute and just talk a little bit about this issue of secondary findings, given that it's been such a controversial issue in the literature. In particular, last March, the American College of Medical Genetics and Genomics actually came out with their official recommendations regarding how labs should deal with secondary findings, and came out with a list of conditions and genes and variants where patients really shouldn't have a choice. They would really, it would be a requirement of undergoing sequencing that patients receive those findings. And these recommendations have been very controversial and have really prompted a lot of opinions, pieces, and commentaries about this general area. And one thing that I think is very interesting about this is, you know, the extent to which we really have empirical data that can inform our sort of policies and procedures about returning secondary or incidental findings. These data that I'm showing in this slide here were compiled by a postdoc in my lab, Debbie Bolt, who's been very interested in this area and reviewing the literature on secondary and incidental findings. And, you know, what you can see here is that, you know, there have been a lot of sort of opinions and commentary pieces published over the last few years on this issue. There's been some data on people's sort of attitudes and perceptions of, you know, whether or not these findings should be available. We've seen some reviews, we've seen some studies that have estimated what the actual frequency or likelihood of seeing incidental findings would be in any given population. But when we go down to studies that have actually, you know, to some extent returned incidental findings and actually sort of measured the impact of doing that, there have been very, very, very few. And so I think, you know, it's important to consider how, as a field, we might start to do more empirical studies on what the actual impact of different policies towards incidental findings might actually be. Okay, so now I'd like to talk a little bit about the return of results between the physician and the patient in some of the data we've seen in our study. And so what I'd like to ask you to do right now is to think about the last time or the last few times you saw your own physician, and think about how you would rate your physician in terms of their knowledge of the issues you brought to them, their explanations to you of those issues, the extent to which he or she solicited your questions, the extent to which he or she spent time, you know, appropriate amount of time answering questions, repeating information, just kind of their overall communication report card, if you will. So I would like you to think about that a bit as we go through these next few slides. So we essentially asked this question of patients in our IDIOM study, and what you can see here, I'm going to show you data for the first 5 cases. The y-axis reflects scores on the medical communication competence scale, and the blue bars that I'm showing here represent how the patient rated their physician in general. So this was done pre-sequencing, and we said, you know, how does your physician do generally in terms of explaining things, in terms of their knowledge, in terms of soliciting your questions, and so forth. And what you can see here is that for the most part, among these 5 cases, the patients are saying, you know, our physician does a great job. They explain things very well. So what we did then was in the post-sequencing assessment, we asked the patient to do the same thing, but to specifically comment on the physician's communication around the return of the sequencing results themselves. And this is what we're seeing. So for cases 1 and 2, you can see that in general, patients were very satisfied in terms of the physician's return of sequencing results, and very comparable to how the physician, you know, sort of communicated with them in general. What we see, however, for cases 3 and 4 are a bit of a discrepancy, where the patient is essentially saying, actually, the physician you know, didn't do as well with returning sequencing results as he or she does in general. So then what we did in this protocol is that we also asked the physician to kind of rate him or herself on how they did with regard to return of sequencing results, just to see how well that mapped onto how the patient viewed that return of results encounter. And what you can see here is that for cases 1 and 2, the findings are pretty consistent. We're seeing fairly high ratings by the physician, the patient, and the patient. Excuse me. However, when we start to get to case 3, a little bit problematic. We're seeing a physician who has said, actually, I did a fairly good job of returning those results, but this is kind of a discrepancy from how the patient viewed that return of results session. Essentially, the patient gave the physician sort of a failing grade, if you will, with regard to return of results. And then in case 4, that's also sort of an interesting case. We're seeing that the physician felt that he or she did a poor job of returning results, even though the patient felt that it was fine. So I'd like to delve in a little bit deeper into case 3 and show you a bit about what the patient and the physician and the family actually reported with respect to this return of results encounter. So what you're seeing here is on the x-axis, the different questions, sampling of the different questions we asked. So knowledge about genetics, knowledge about whole genome sequencing, how well the physician explained what the results were, reviewed or repeated important information, ensured that the patient understood, encouraged the patient to ask questions, spent enough time, and then also how did the session go overall. And so and this is case 3, once again, the one where we found a significant discrepancy. And should be showing you results for physician, mom, and dad. And so what you can see here is that these are the data from the physician in red. And I was actually received the physician's assessment back first for this case. And was encouraged to see that this physician felt that they did quite a good job at these various domains for the return of results. Then we received the results back from mom and dad, and it's interesting what we're seeing here is that mom and dad agreed that in fact the physician did seem quite knowledgeable about genetics, knowledgeable about whole genome sequencing. However, when we asked mom and dad some of these other issues, we're seeing a pretty striking discrepancy between how mom and dad viewed that return of results versus how the physician viewed it. It's, there's a lot of, when we asked mom and dad, how well did the physician explain what the results were, they basically disagreed that this physician did a good job. In this case, mom was a little bit more forgiving than dad, but in general, both of them were pretty dissatisfied with the return of results overall. So actually, going back to this, this actually prompted, for this particular case, just to provide a bit of background, when we saw these results, we actually reached out to a different physician on this patient's team and actually conducted a second return of results to try to sort of alleviate this particular issue. So we learned a lot from this case. And so, these issues around miscommunication obviously can lead to mistakes, misunderstandings between patient and physician, as well as just general frustration on the part of both parties. And certainly with case 3, I will say that the family was very frustrated. And so I think it's only one case, but it can be instructive for thinking about return of results in these types of cases. So what about post-sequencing, some of our other observations? we one example is that kind of some themes that we've seen. The physician from case 1 said, and this was a physician where both parties thought that the return of results went very well. This physician said, we took several hours post-testing to discuss results, which is not feasible in general practice. So getting at this issue that's been discussed widely in the literature that, you know, in a typical physician office visit that lasts, you know, 5 to 7 minutes, there's not enough time to go over, you know, results like this from clinical sequencing. So how do we address this issue was pointed out by this particular physician. The patient from case 2, one point that she made was make it faster so it's more relevant. Again, getting at another issue that's been discussed widely, which is turnaround time, and how can we lower that turnaround time. And then finally, ironically, the father from case 3, and you're probably not surprised at this quote given the data that I just showed you, said, do not depend on a child's doctor to transfer such important information, which is a pretty incredible quote when you think about it. You know, the idea that this father had you know, higher expectations and you know, perhaps felt that you know, there needed to be some other system for him to be able to get this information about his son. And from more of the quantitative measures that we administered, we looked at kind of test-related distress or sequencing-related distress and regret. We saw, you know, almost no distress among these patients, very little regret about going through the study or anything like that. We also asked this group of patients and physicians the extent to which they felt that another clinician should be involved in this process, and 75% of the physicians and 50% of the patients suggested that an additional clinician should be involved. The two most common types of clinicians mentioned were a genetic counselor to better understand the genetic results, and then also a psychologist to help patients kind of understand or deal with the implications of the results. For example, whether or not the results are actionable, or whether or not the results actually had a finding that you know, could provide more information about the diagnosis, because not all of our cases actually uncovered the genetic diagnosis. And so what about barriers? I think we've encountered you know, a lot of the barriers that it's kind of the usual suspects, the barriers that many people are experiencing who are trying to do this type of work. Cost, efficiency, privacy concerns, turnaround time, as I mentioned, too few genetic counselors. One reason that we utilize physicians as kind of the primary point person to return results is that there are so many more physicians than there are genetic counselors. Only about 3,000 in this country, genetic counselors. So it's about 1 for every 130,000 people. And so if clinical sequencing were to become much more widespread, there would be, you know, a problem if we felt that genetic counselors needed to be involved in each and every case. And so in utilizing physicians as a primary sort of point of contact in our study, we felt that it would kind of be more ecologically valid, more sort of real world, if you will. And then also the issue of physician training, which has been, again, one of these hot button issues that's been widely discussed. What you can see here, this is a compilation of some of the genomic medicine initiatives in this country up until about spring of this year. I'm sure there are a few more at this point in time. There's about, and this is very encouraging, a number of these schools sort of developing genomic medicine curriculum for undergraduates, for medical students, and so forth. But I think what's also important to realize is 16 initiatives, but there's actually over 140 accredited medical schools. So, this isn't a new issue, but certainly the issue of physician training sort of looms large in this space. Another initiative that we're pursuing at Scripps to try to further build on some of the ideas and the results that we've seen in IDIOM is actually a partnership with several primary care and internal medicine and family medicine physicians here at Scripps who have signed on to participate in a study where each of them will enroll 4 to 6 patients. Those patients will undergo sequencing, and these physicians have all signed on to try to return results to these patients and further explore that process and how we can effectively integrate genome sequencing into medicine and into primary care. So we're looking forward to that initiative. So just to conclude, I want to revisit kind of the main points that I mentioned at the beginning of the talk. I think one of the observations, and I'm calling these observations because this is case study data. This isn't a large randomized controlled trial. But I think we're seeing some hints that, and it probably doesn't surprise anyone, that physicians as a group kind of may need help with genetics. And in some cases, like our case number 3, they might not know it. So really, further, understanding these issues and trying to figure out how we can increase support for physicians and training is obviously very important. I think another important point, take-home observation, is that patients, families, and physicians would kind of more often than not choose to receive some, if not all, secondary or incidental findings. So kind of a message that these individuals want access to their own data, want any and all data and findings that are available. And so thinking about how to do that, how to, potentially provide patients with the choice about which findings they want to receive. I think further exploring that issue with empirical studies is going to be critical. As I mentioned, there's a lot of commentaries and opinion pieces about this, but better understanding what is the impact of delivering incidental findings on the patients, on the system, the healthcare system, I think is going to be important going forward. And then finally, just to underscore this point again, is that patients in these early studies, or at least in our early study, this diagnostic odyssey type study, are not, and I don't think this is a surprise to anyone, are not your average patients. People who may be benefiting from sequencing in these early stages are people who are kind of very aware, very savvy, potentially have a lot of financial resources. So thinking about how we can ensure that these services and this technology is available to all types of patients who may benefit, I think is also important. And I just want to acknowledge many people here at Scripps who have made these studies possible. It certainly has taken the involvement from many people in our group to get this study off the ground and to run these patients through. So very, very appreciative here. So that's the conclusion of my talk. I'll take questions now. Okay, so I have one question here. Let me just read it. An extremely interesting study, a number of suggestions and hints appeared. As far as I understood, 5 patients were enrolled, starting from approximately 100 eligible cases. For some metrics, only 4 cases were evaluated. How did you address the possible biases linked to this low recruitment rate? Have you planned subsequent studies? So this is a great question. I think just to kind of clarify a bit more, the 100 cases that I mentioned in the beginning were actually not all eligible. So these were all of our referrals. Many of them, did not come even close to meeting our inclusion criteria. So we basically, as I mentioned, the process is that for cases that appear as though they might meet criteria, we bring them forward to undergo panel review by our clinician scientist panel. And then from there, that panel actually chooses who to enroll. And so we've actually never had an instance where the panel has voted to enroll a case, but that family has declined enrollment. So I certainly agree that this is a very kind of biased selected sample. And I sort of intended to elucidate some of those biases by kind of showing you some of the patient characteristics. But I don't know, hopefully that kind of clarifies some of the questions. Thank you for the question. Okay, so here's another question. Based on the information you provided, could it be possible that genomic screening, data analysis, and counseling could be taken care of by private industry rather than physicians? Patients could then use such information to subsequently go to a physician for treatment only. Sounds like the medical community could be overwhelmed with the amount of work necessary. I certainly think that I certainly think at this stage, in many cases, the medical community is overwhelmed with all the information that comes from genome sequencing that's certainly been widely discussed in the literature. I think figuring out the best model for delivery of genome sequencing is really kind of a charge for the field and for the community. So whether or not private industry would be the place to do much of this work, I don't know. I mean, my sense is that ultimately a partnership between the patient and their physician with perhaps a lot of support for the physicians may be a better way to go. But I think to some extent it's an empirical question. I think we need to do the studies to better understand what would be optimal. Thank you for the question. Okay, so the next question, were there any minorities included in any of the cases? Patient trust and cultural competence of physician would be important in the interpretations as well. Or was there a low response to the call for case in minorities? I'm sure I understand all of what's written here in this question, but I think the general idea from this is that, to what extent were underrepresented minorities included in the study? And I think it's a great question. Out of the 5 cases that I presented, 4 of them were of European background. 1 was Latina. So I think, there's certainly an issue with, being able to recruit sort of a more diverse patient group. And again, this is something I was sort of trying to get at when I explained how, these patients are not your average patients. They're highly educated. They have high incomes. They are very savvy. They've worked the medical system up until this point on their diagnostic odyssey. And so I think, but in addition to that, and something I didn't mention, but I think is important, and thanks for the question because it gives me a chance to mention it, is that making sure there's a diverse sort of ethnic, racial representation in these studies is critical. Okay, I'm not seeing any more questions at this point, but I'll wait a couple more minutes. If any of you have questions, please send me your questions. All right, I'm not seeing any more questions at this point. Of course, feel free to email me if you have any questions. My email is cbloss, so CBLOSS at scripps.edu. Happy to answer questions via email, and I really appreciate your attention. And I'd like to thank the conference organizers for inviting me to present. Thank you very much.